Stuck between two USMLE answers and choosing wrong? Here's the exact method that helps my students crack any difficult question. You might think you need to memorize more facts, but after hundreds of tutoring sessions, I discovered something game-changing. There's a systematic way to solve hard questions with knowledge you already have. Watch real students work through questions they got wrong and see the exact process that turns difficult questions into easy points. This isn't about knowing more, it's about thinking better.
I found that sometimes, like with management, like you'll see in these, there was like one question that was like I know that both barium swallow and EGD would like look for like a tumor or structural issue, but why was it like EGD and not barium swallow? Like I found that type of issue more.
I see.
And when I read the answer, I'm like, oh, that makes sense. Like it's more specific for, and it's more detailed. You can get a biopsy in there, but I get confused sometimes with like, what is like the first, do we do the first least invasive option, or do we do the like rule out like the worst thing possible first?
Yeah. Do you have one of those questions here?
Yeah.
So if you start the diagnosis. Okay, so let's go through this one. What I want to do with this is, let's actually just go through the QI process. So I'll have you read through. I'm going to have you stop at every sentence, adjust for context, chronology, severity, and then we'll get to the standalone question. And then I want you to do rule in and rule out.
57-year-old man. So he's a middle-aged man, presents with 3 months of intermittent chest discomfort after meals. So this has been going on for 3 months, and it seems more of like either a GERD issue or a structural issue. He describes a sensation of food getting stuck in his lower chest, which improves after drinking large volumes of water. So this seems more of like a structural issue, and it's been occurring for 3 months without any sense of getting better. So it seems more of like a chronic issue that we need to address. He has a 20-year history.
So when you're thinking of like dysphagia, what are the two sort of like categories of dysphagia?
There is like a structural issue, like achalasia or something like that, or like a malignancy.
Yes, structural is one. Achalasia, actually, I would put in the other category.
Okay.
So there's like problems of motility,
Yeah.
like peristalsis, and then there's problems of like the structure.
Okay.
So structure would be like cancer or I don't know, stricture or something like that. And then the other is like, you just have a problem with like
the nerve,
the actual motility of the esophagus.
Okay.
So if it's a motility problem, how does it present? Versus if it's a structural problem, how does it present?
Motility issues motility will still occur over hours. It's just that it's like going to be slower. But when...
Yeah. Motility is typically food and liquid.
Yeah. Okay.
Structure is food first. And then if it gets worse, then liquid later.
Right. Okay.
Does that make sense?
Yeah.
So what does this mean?
This is just with food, and it improves after drinking liquid. So it would be a structural issue.
Probably structural. Oh my God. Okay. All right. Next.
He has a 20-year history of GERD and is on a proton pump inhibitor. So chronic GERD, this could lead to like dysplasia and like of the cells. And then if you're thinking like, I don't know, carcinoma, maybe that it's like causing a structural issue that's making it difficult to swallow foods all the way down.
Yeah, totally makes sense.
He drinks 3 cups of coffee.
Oh, context, chronology, severity. So which one would be best to address?
It would be chronology in this case. So
yeah, good.
He has GERD for 20 whole years on a proton pump.
But you should say a 37-year-old guy has GERD.
A 37-year-old man has GERD for 20 years. And then
20 years later, he has...
20 years later, he has intermittent chest discomfort after meals. And 3 months later, he comes into the office.
Yeah, essentially. Yeah, I'd say like a 57-year-old guy has GERD. 20 years later, he has dysphagia for solace. It's just like, this gets worse kind of over the course of 3 months, and now he's in the hospital, comes to the doctor.
Yeah.
Cool. So when you say it like that, I mean, you did a good job because you already kind of picked it up.
Okay.
Of like what you thought might be going on. But if you put it in chronological order, it like virtually always makes it easier to figure out what's going on.
Yeah, that's true.
So, okay, great. All right, next.
He drinks 3 cups of coffee per day. So that's probably trying to say coffee's acidic, so it might make the GERD worse. And 1 alcoholic beverage nightly with dinner. So nightly with dinner for how many years that could be contributing to like a development of the malignancy in the esophagus. And he's obese as well. So that could also be contributing to the GERD. What is the most appropriate next step? And I don't like these like next step things. I almost always say like, what is like the first step when you're trying to diagnose or trying to rule out gastric adenocarcinoma? But that's just what I feel like was helping me because the most
Yeah.
appropriate next step.
Wait, gastric?
Or no, sorry, just esophageal carcinoma.
Yeah. So your second question again is what?
What is the first step in diagnosing an esophageal cancer?
I think they're just saying like, how would you diagnose or how would you work up suspected esophageal cancer? Or probably an easier thing would be like, how would you work up some kind of structural obstruction in the esophagus?
So like sometimes they ask what is the most appropriate next step, and then sometimes they ask what tests will confirm the diagnosis. So like I think that's where when it says what will confirm the diagnosis, it would be like the EGD and biopsy, right? But then that's why sometimes it's confusing.
I know. I think what you're doing though is you're saying like, you know what you would do to confirm it. Therefore, that must not be the next step. Because the confirmatory thing, like you're assuming that there's going to be, you're kind of like presupposing that there's going to be some other step that must precede the confirmatory step.
Okay.
Because I think if I understand correctly, your reasoning is I don't want to do that thing. Like the confirmatory test is never the right initial step because I'm going to save that to do later.
Yeah.
Like that is almost definitely not true.
Okay.
Right.
Yeah.
Cool.
Yeah.
So your interpretation was pretty good. I would for your chronology again, remember, make it present tense every time.
Okay. Rule in, rule out is like easy to kind of say that you're doing it, but like it's harder to check that you're actually doing it. Like you can say
All right, let's do it. That's a good one. Okay, so I want you to rule in and rule out each of these answer choices.
Okay, so coronary artery disease, CABG, and then exertional. So he has peripheral arterial disease. Okay, so rule in for abdominal aortic dissection is that he has risk factors for atherosclerosis, and that could weaken the the aortic wall, and cause dissection eventually.
I would say the rule in is actually that like you can get hypertensive, right? Because if it dissects, you're essentially increasing the resistance in the vessel.
Right. Okay.
So that's why you can get those asymmetric blood pressures.
Okay.
Yeah, like you can get asymmetric blood pressures because you can compress one, either like sort of basically one of the subclavians or like before one of the subclavians and not the other.
Okay. Got it.
My guess is the other thing is that he's got lower extremity pulses are diminished. So like that's the other kind of thing. So it's like he does like it is potentially the setup. Like I could imagine a situation in which it dissects, say, distal to both of the subclavian arteries.
Right.
And so like everything upstream of the dissection would have a high blood pressure and then everything downstream would have decreased flow. So that would make sense.
Okay.
I can imagine a scenario in which that would be true. So that would be the rule in. What would be the rule out?
The rule out would be like he's here for a follow-up, and an aortic dissection would present more like urgently with like a,
That'd be a weird dissection. Yeah. Plus like the labs don't make any sense.
Yeah.
Yeah. That'd be weird. Like no pain. Like it's just like the only presenting symptom is like, like high RAS and yeah. Maybe a little weird. Okay, essential hypertension. What's the ruling?
The rule-in is elevated blood pressure that's persistent over several months, and the rule-out is the hypokalemic metabolic alkalosis and the lower extremity pulses are diminished, and yeah, it should be good.
Yeah. Well, and like prerenal AKI, be a little be weird. Or like that would give you like an intrarenal AKI,
Yeah.
essentially. Honestly, I think this is noise. I'm pretty sure that's noise because they're just telling you that he has peripheral vascular disease,
Yeah.
right? So like this is just a sign of peripheral vascular disease. So like that isn't really a way to rule out like essential hypertension because that's completely different.
Yeah.
All right, renal artery stenosis. What's your rule in and rule out?
Rule-in, he has like a predisposition of hypertension, and he has a prerenal AKI, and it's affecting the filtration system of his kidneys. So because of increased ROS, he has a hypokalemic metabolic alkalosis.
Yeah, I would say like the rule in is it's pretty classically renal artery stenosis. It's like normal, 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 and then like massive high increase in blood pressure over a relatively short period of time. And he's got hypokalemic metabolic alkalosis with like prerenal findings.
What did you just say? That it's like normal and it's randomly high? Is that what you said?
Well, it progressed pretty quickly. Like if this was essential hypertension, like, I mean, this is a guy who he had a cabbage 4 years ago.
Yeah.
Right? Like when he was 73, he had a cabbage. Like I'm shocked that he doesn't have high blood pressure.
Right.
Right. Like this is the person where I would have assumed that he had essential hypertension to begin with.
Yeah.
So it's kind of a miracle that he has normal blood pressure. And then, but it was like normal past several months, right? So basically like a 77-year-old, let's see, how would I rearrange it chronologically? Basically a 73-year-old guy has such bad coronary artery disease that he gets a cabbage. A year later, he basically has like peripheral vascular disease. And then 3 years after that, his blood pressure was essentially normal, but then now over several months, it's like super high. And he's got like a high, he's got high RAS and like a prerenal AKI.
You know, I just realized I missed the sentence of the normal blood pressure for the past 2 years.
Oh, yeah.
Maybe, I think sometimes when there's like labs, I rush through the vignette a little bit.
Mm-hmm. So one way that you can address that, because usually when people say that, it's because they're nervous about something. They're like nervous about the labs coming up, and so they're like gonna rush through that thing. As a general rule, if something makes you nervous, that's usually a good thing for you to work on. So I would use the USMLE GPT to like design scenarios where like it forces you to like, so for example, if I'm weak on LFTs, I should use the USMLE GPT to be like, give me different scenarios for LFTs.
Okay.
And then force me to kind of like justify my reasoning around those things. Let's just do D for rule in and rule out. We'll skip E, but let's just do D.
Chronic kidney disease would have, a rule in is that, I guess, like the hypokalemic metabolic alkalosis. And maybe like the history. No? Okay.
Because remember, if you have chronic kidney disease, you don't filter stuff out. So you accumulate acid and you accumulate potassium.
Yeah.
Like what's the typical history of someone who has CKD?
Usually like diabetes.
Yeah. Yeah. So if like they've got bad, vascular risk factors. So like hypertension, diabetes, hyperlipidemia, that kind of thing.
Yeah.
Okay. So what's the rule in for CKD?
Maybe the peripheral vascular disease.
Yeah, I would say that the rule in is that the same risk factors that make you like have bad vascular problems like CAD, PVD, are also the same risk factors generally that give you CKD.
Right.
So he's kind of the classic setup for it. And it can give you high blood pressure. And you would have, an AKI of some kind. Not AKI, but like you'd have high creatinine.
Yeah.
You'd have a filtration problem.
right?
Mm.
Those would be the rule in. The rule out is that like your labs would look very different, right?
Yeah.
Your creatinine would be higher,
Right.
like your creatinine elevation would be higher than your BUN elevation, and your potassium would be high and your bicarb would be low.
Right. This one, I got confused here because I didn't think it was CLABSI because basically they didn't say anything about his like.
Okay, well, hold on. Whoa. Okay, so these are my favorite. So remember this technique because this will work well for your test, and it's like 40% of your test. So this is a really good one.
Good.
Like whenever I get a management question wrong, I like to look at the correct answer, and then I like to look at the answer I chose, and then I like to play a game where I go back and I try to guess what the severity was.
Okay.
So if the answer was blood cultures from catheter site and it was not section of fistula, what do we know? Like, if I go back, what am I going to expect to see for the severity of this condition?
If I knew that it was blood cultures,
Yeah. The answer, if you knew the answer was blood cultures, like, what would you guess is the
way
severity?
more stable.
Yes. He's not like dying. He's not like, so his vitals are like, might be probably not that concerning, honestly. So let's see if that's true.
His systolic.
Wait, he is shocked. That is shocked. Yeah. So this is really shocked. Ostomy, blah, blah, blah. 3 days ago, leukocyte count says 14. Yeah. I mean, like, it's definitely a problem.
I didn't really read that, like, okay, like, they fixed the fistula, like, they fixed the bag. Like, okay, exam shows fistula opening, draining, and carry contents. An ostomy pouch system is placed, and the surrounding skin is well protected. Like, okay, they already fixed the fistula. They don't.
Did you rearrange it chronologically?
I think that was my problem. I think I just didn't rearrange it in this time because I think for me, I was like, oh, well, maybe his fistula is like, maybe there's still the fistula or it's like still leaking, even if there's an ostomy there, like maybe they missed part of it. Like,
I know. But again, so let's rearrange it chronologically. So a guy what?
a guy had a lap for a gunshot wound. Then a week later, while he's in the hospital, he has a fistula. The fistula is noted. And then well, actually, sorry. Let me add one more thing.
Yep.
A man gets gunshot wound, comes to the hospital. He has an X lab for this gunshot wound. And in the hospital, he's put on TPN through some site.
You got it. Yep.
Then while he's in the hospital, they also notice that he's doing well. He's doing well in the hospital. Okay. Everything's fine. But then they notice that there's a fistula about a week later, okay, while he's in the hospital. And then, when they notice this fistula, he all of a sudden spikes a fever. His pulse is high, his respirations are high, his blood pressure is low, he's in some sort of shock. So then what do? They, because they realize that this fistula is draining enteric contents, they put an ostomy pouch. And then they kind of clean it up, skin's fine, and the fistula output is draining his content, so it's working well. But then, okay, this is my problem here, is I think where I got mixed up was I didn't, like this 3 days ago thing, I didn't really know if like this 3 days ago was before this whole they put this ostomy pouch in thing, or if it's like, when is this happening, right? Like, is it in between the fish, like they're putting the ostomy pouch and now, or is this after the ostomy pouch?
Yeah.
And then it's saying that like 3 days ago before the fistula bag was placed, he had
Did you rule it in first before you ruled it out for A? Like, what was your rule in for A?
Well, I thought that, the thing was, I was like, if he's septic for any reason and he's in shock, what's the more severe thing that you're going to do for this guy?
No. But again, you're ruling it out. You're ruling it out first. Try and identify, because every answer is the right answer for something, every answer choice. So what does A represent?
A is like he has some sort of infection. I mean, well, from the catheter site, he has an infection of the catheter site.
He's got a line infection, right? So the rule in is that this is a line infection.
The line
Which
infection, they've been distracted with other things. They've forgotten to change his line.
exactly, right? His line has been there for 4 weeks, and not just that, but they're running like basically like just crazy amounts of, bacterial culture media through it.
But yeah, this was like super, like on the timeline, it was confusing because basically I was like, okay, they're placing this ostomy pouch and they're telling me that over the
I know.
past 3 days, the thing has spiked, right? So it's like, okay, well, it's probably due to the fact that he's leaking like his bowels into his abdomen. That's what I thought.
I see what you mean. Yeah, I agree. That is weird. Like, I'm not sure if they mean like it's been for the last 3 weeks. This has just been like, soaking his bed, which probably I would imagine is not true. It's like they probably, when they say they placed it, maybe they mean like they replaced it. Like they like took it down to like look at it, and when they placed it, they put it back. Honestly, I agree. That's like
Sense-ish. They're like, oh, there's no peritonitis on his.
could have been worse. So I think what I would say is that again, what I'm trying to find is the patterns. So in general, if you find yourself making, like, yes, there's some things that you don't know about knowledge, but like your knowledge is good. Like your reasoning is quite good. So like, I don't know, like this was good. Like you know what a CLABSI is. Yeah, it's like, so all of these things are good. What I want to do is I want to tap into that knowledge so that you can get more questions correct for the knowledge that you have. The one thing that you can do that will almost always increase your likelihood of getting the question correct is to try to rule in it first.
Right.
And by ruling it in, what that means is that you want to figure out what is that answer explanation going to say when you look at the answer, like once you go through and look at the answer explanation. And so you want to be able to say, oh, okay, A means that this is a line infection. And then you say, okay, does line infection make sense? Wait a minute. He's had 4 weeks of TPN and they haven't changed his line. Like, no, like that would actually kind of fit, right? The rule out is
What the severe, like when I was thinking about the severity, I was like, well, like,
I get it. No, I understand what you mean. But again, what's the diagnosis and what's the severity are the two questions. You can't just use severity, right?
well, I mean, at the end of the day, like if this guy is septic, you want to give him antibiotics stat, even if it's from his fistula or if it's from his line. Like, so it does kind of make sense that regardless, either way, you would probably want to run some blood cultures and give him some antibiotics to get him out of his septic shock, basically.
Yeah, totally. So I think this was an issue of, sometimes people call it chunking. We think of this as like context, right? So oftentimes what people struggle with is that they're not sort of stopping at the end of every sentence and asking themselves like, okay, like what exactly is it that they're asking? What exactly is it that this means?
Okay.
So my guess is that at the end of this sentence, you didn't stop to think like this sentence. You didn't, like, did you stop and say like, okay, like what exactly, like what therapy are they talking about?
No, I didn't.
Would you have known it? Like, would you have known that the next step was infliximab?
I don't think it was like automatic enough to know it in the moment, but
Okay.
yeah,
Which is okay. So how could you have caught it if that was true?
like you don't want to start someone on a biologic, which kind of like decreases their immune response without screening for something.
Did you do rule in and rule out?
So I really did try on every single question. It's just that I didn't I think because I didn't know, or I didn't think of the biologic therapy, and that I just really didn't even know what it was asking to even do the rule and rule out.
I see. So you got kind of like confused by not confused, but like you got kind of overloaded with all of these details.
Yeah.
And then because of that, you kind of took your eye off the ball and didn't interpret as much for the last half of the question.
Right.
I see. Okay. So let's practice that. So read for me kind of the first part of the question, and let's do context, phonology, severity. And so what I'm going to do is I'm going to be extremely annoying because the best forms of learning all involve immediate feedback.
A 59-year-old female with a 5-year history of ulcerative colitis. So she has a chronic disease. She presents to discuss new treatment options. So I'm assuming she still has symptoms after this 5 years.
Okay, good. So that's a lot of words. Can you summarize it more quickly? Like, can you summarize it with fewer words and more conceptually?
Middle-aged women with
So it says 54-year-old woman, right? So they've given you the time frame. So 54-year-old woman.
54-year-old woman gets diagnosed with ulcerative colitis, and 5 years later, she comes to the office to find new treatment options.
Yeah. Well, basically, like a 54-year-old woman has UC, gets treated for 5 years, and it's still not working.
Okay.
Something like that.
Okay.
Okay, great. Next.
She's not responded to prednisone and mesalamine, so she hasn't responded to the first-line therapy.
Great. Perfect. That's fantastic, right? Like, is it that important, like, what the therapies are?
No.
Like, maybe, but probably not, right? It's like, presumably they're going to start on, like, first line. Okay, so great. Yeah. So you already kind of knew that they were going to say that based on your analysis because of the way that you framed the first sentence. Okay, next.
Her past medical history includes asthma and Ehlers-Danlos syndrome.
Okay, so what do you think?
I mean, she developed Ehlers-Danlos syndrome, or she was born with it, and then developed asthma, and now and then 5 years ago she developed
Why are they telling this to you though? Like you want to analyze this from like what's the purpose of the sentence?
I'm not sure.
Yeah, honestly, I don't know. Like, this could be signal, this could be noise. Like, you don't know, honestly. Like, at this stage, I don't think we have enough information to know. I'm not entirely sure how Ehlers-Danlos plays in with UC.
I know.
Like, I'm not really, and asthma, kind of same thing. It's a little weird, right? So, like, I'm going to keep that in mind, but, like, I'm not, I'm also open to the fact that those could both be noise. I think the difference between what I did and what you did is that I just said objectively, I don't know what this means. You took it personally. Right?
Well, yeah.
You were like, oh my God, I don't know what this means. And therefore there's something wrong with me.
Yeah.
Right?
Yeah.
Do you see the difference in how like we will read the rest of this question?
Right.
So part of it is, I know it sounds so stupid, but like it's so simple. A lot of it is just that like you have to not take these things personally.
Yeah.
Right? You have to know, like, start with the assumption that you are good enough and that you, like, if you have put in enough work that if you don't know what it means, it probably means that, like, no one's going to know what it means.
Okay.
Or, like, a very tiny percentage will know what it means. Okay, great. Next.
She has Cushingoid facies and mild lower extremity edema. I also wasn't sure about this one.
Yeah. Okay. Well, Cushingoid facies. So, like, mild extremity edema, sure. But, like, Cushingoid facies, can you figure out, like, why would they tell you that?
Because
So, context, phonology, and severity.
in context, she's taking prednisone and mesalamine, and excessive steroid use could cause Cushingoid features.
Good. So, what's that telling us?
That she is on the max dose.
Yeah, exactly. Like it's not like they're like giving like a weenie dose of steroids. Like they've gone all in and it's still not working.
Why couldn't I do that on the exam? That's so weird that I could do that now.
I think it's because honestly, I think it's a mindset thing. Like you started with the assumption that you didn't know, and therefore you found evidence to support that. You can do this. You just have to start with the assumption that you can do this.
Okay.
Right? Okay, next.
She's allergic to sulfonamides, so we can't give her a sulfa drug so that next therapy is ruled out.
So is it signal, noise, or indeterminate?
I still feel like it's noise just because you would start on like anti-TNF therapy anyway.
Yeah. It's like either indeterminate or it's just noise, right? Like at least it's not obvious to me what the reason why they're telling this to me. Like the Cushingoid facies, sure. Like I'm pretty sure I know what that means.
Yeah.
Right. The like prednisone, it's like okay, great. But like, so far, I mean, that's just they're just kind of like filling noise. They're kind of just remember that the questions are written in order, just like an H&P or like a normal sort of presentation would be. So this is, the first sentence was the chief complaint, right? Not responded to prednisone and mesalamine. That is basically her HPI. Her past medical history, they actually say as her past medical history, right? Now they're in it's a little weird that Cushingoid facies is like, that actually should not be that, right? Allergies should be before this. But like the cushinite feces, that's the exam.
Yeah.
Right. So cool.
Yeah.
All right, next.
Physical exam and labs show no acute findings except elevated white count and anemia. I mean, elevated white count maybe could be associated with ulcerative colitis if they have like
Possible. What's the other possibility?
some kind of infection.
Yeah, sure. Yeah, maybe. I mean, but like in this context, like, can you think of another reason why?
Like neutrophilia.
Good. From what? What is she taking?
Prednisone and Misone.
Yeah. So which of those drugs could affect her white count?
I'm not sure.
So remember, what effect does steroids have on your white count? Like on your CBC and your diff in particular. So my guess is like, so either this is because she's got UC that's uncontrolled and it's like a sign of inflammation, and or it is a sign of like her having just taking steroids.
Correct. Yeah. The medical team's considering starting a biologic agent for her IPD.
But so again, so what you don't want to do is you don't want to regurgitate exactly like the words that they're saying. So like, for example, in the first sentence, you wouldn't want to say like, oh, she's coming here to, like a woman with a 5-year history of UC is coming basically for new treatment options, right? You would say a 54-year-old woman, chronology, 54-year-old woman has UC and basically has failed therapy for like 5 years.
Okay.
Right. So same thing with this, like what exactly, like if you could sort of get to the concept, what's the key? If there's like one key word here or two, what would it be?
Biologic.
So what's the standalone question now?
What step do you want to take or what do you want to check in a patient who is about to start biologic therapy?
In an ideal world, you would know what biologic they're talking about, right? So you would want to stop and think like, okay, so biologic, like what exactly does biologic mean? Okay. I mean, technically it can be a lot of things. Like I think technically resveratrol is like a biologic, but like most of the biologics I know of are antibodies.
Okay.
Right. So it's like if you're going to start and then so you want to think, okay, what antibody is this going to be? And then ideally, you know the antibody. If you don't, that's when you would do, I mean, regardless, you would want to do rule and blood.
Okay.
So A, what does A mean? Like, what is A there for?
Because they talked about asthma and PS.
Oh, maybe. They may be trying, this may be like a TB thing too.
Okay.
Right. That's like checking for active TB.
Right.
Right. That's probably my guess.
Like the second step after if the PPD came positive, is that what it?
I get. Yeah, exactly. Yeah. Like if her screen was positive and you thought she had active TB, sure.
I don't.
So, but that's, so there's, I think, multiple things that you can improve on this one. I think the biggest one is you have to learn how to put your nickel down. Okay. Again, there's like multiple things. The reason why rule and blood is so nice, if you can get really good at that, even if you missed like what's going on in the question, you can save yourself on the back end.
Okay.
Right. You'd be like, okay, like tuberculosis screening. Oh, I guess that would be if you're going to do something that's like anti-macrophages. Oh, oh, that's probably what they mean. Okay, sure. That makes sense. Right. You want to rule it in first, figure out like what the heck they mean. And then be like, okay, actually that does make sense. Okay. I can't rule that one out. So let's keep that for now. Cool.
Yeah.
Now you've seen the exact process for working through impossible USMLE questions, but here's the thing. Even with perfect technique, there are hidden factors destroying your score that nobody talks about. In my next video, I'll expose the NBME data they don't want you to see, including why 1 in 4 students scored 20 or more points different than predicted. You'll discover why using step 1 strategies on step 2 is killing your performance, and the shocking truth about why 50% of missed questions have nothing to do with knowledge gaps. Click here to watch 10 step 2 score killers you're probably overlooking and find out what's really standing between you and your dream score.